So dear ELPA friends and all others in the general public that are highly interested in European projects, and especially European projects called Decision. So this is the COMBAT trial. We will speak today about a novel combinatorial therapy with albumin and enoxaparin in patients with decompensated cirrhosis at the highest risk of poor outcomes. This is an event, this is a layman event where we will try to answer all the questions that patients might have. And even if you have questions later after listening to all the presentations and participating in the discussion, you can still send us questions to the ELPA office, and we will try to find the right person to answer your questions. But in the year 2023, we will see a beginning of a clinical trial. And for the trial, we have many questions and concerns in regards of patient community. So for example, which are the centers where this will go on, who can participate, how can you participate, maybe concerns in regards of ethical and moral questions in participation in such a trial. So these are some of the questions that we will try to answer today. And in regards of the EU project, so Project Decision is European Union funded research projects that aims to better understand the late stage liver disease, or as it's called, decompensated cirrhosis on acute on liver failure, and to develop a new combination of therapies that could be beneficial for the patients. So in this second phase, exploratory, open-labeled, multi-centered, randomized clinical trials will begin in the year 2023, in which all treatment groups will receive human albumin and enoxaparin on the top of standard medical therapy. This all raises a few questions, and we will try to answer these questions. The agenda for today is as follows. So first, we will start with the presentation of the overall decision projects from Professor Pierre-Emmanuel Ratetou. It is really nice to see you here, Professor. And then later, we will find out something about the COMBAT trial, which will be explained by Professor Paolo Zazzareni. And then later we will see the explanation of the recruitment process that is done by successful recruitment centers. And this will be presented by Carlo Alexandria. And later we will see what it means from the ethical perspective. What does this mean to participate in the trial, which will be presented by Professor Itzar della Corona. And then we will dive into the discussion. So we received already many questions from our members in regards of combination and questions about the project. But without further ado, I will give the floor now to Professor Pierre-Emmanuel to just give us an overview of the project. Professor, the floor is yours.
Thank you very much. It's really a great pleasure to be with you to share what has been done. To share with you what has been done in this project since the beginning of the Decision project, almost 3 years ago. It's important for us because this project really aims at improving the outcome of the patient. Here, you can see the course of chronic liver disease in general, whatever the cause. We start with a normal liver, and after years and years of infection with a virus or exposure to toxic agents or fat, then there is some scar appearing called fibrosis, which leads after usually 20 years to cirrhosis. And cirrhosis is really an asymptomatic disease, but once the symptoms appear, then it is called decompensation of cirrhosis. And this is really a turning point in the natural history of cirrhosis, because the outcome of the patient at that stage completely changes with very poor predicted outcome leading to death or to liver transplantation. And this is really the focus of the project decision to try to address this disease, cirrhosis decompensation, that involves 5 million people in Europe, to try to improve the outcome of the patients. So decision, this is a really big project, 5 years and a half. As I mentioned just before, we are about to start the 3rd year. This is a 6 million granted project involving 10 countries and 21 institutions across Europe. And you can see here these 21 institutions across 10 European countries. So overall, what is the goal of the project decision? This is to change the management of patients with acute decompensation of cirrhosis, again, meaning going from no symptom to symptom. Symptom can be bleeding, gastrointestinal bleeding, can be ascites, can be jaundice, and there are usually triggers that can be bleeding, that can be alcoholic hepatitis or infection. And currently, how do we manage those patients? We treat the precipitating event if there is one. If not, we do not. And we treat the symptoms and the complications. What is the goal of decision? This is the change, really, the management of patients with cirrhosis. And for that, we need to have a personalized medicine, meaning to identify a group of patients responding differently to patient outcome. And for that, we want to take into account specificity of each individual to provide a new combination of drugs. To base this decision project, we are very lucky to have developed by the EFCLIF, the European Foundation for Chronic Liver Disease, 3 big cohorts, 2 from Europe, Canonic and Predict, involving more than 1,500 patients with acute decompensation of cirrhosis and available blood samples, and 1 from South America called ACLARA. So in decision, we are lucky to have big cohorts and many samples from patients with acute decompensation of cirrhosis, and we have also pathophysiological hypothesis to better understand the outcome of patients with acute decompensation of cirrhosis. Our idea is that each individual responds differently to the precipitating events that can be bacterial infection, viral infection, gut translocation, bleeding, or exposure to alcohol consumption. According to the genes, the individual susceptibility, according to systemic inflammation, how the immune system responds to these precipitating events, according to the metabolism, meaning the way the organs behave, according to the crosstalk between each organ, the liver, of course, but also the gut, the heart, the kidney, the brain, then the outcome could be different. There is also this concept of biological age, meaning that if an organ has been exposed for years and years to stress, then it can become more rapidly age senescent, and also the functional liver reserve. And with all these concepts that we want to address and to investigate in decision, then we aim to better understand the outcome of the patient and to try to understand why some patients recover while others go to organ failure called ACLF, acute and chronic liver failure, or die. And the really final objective in decision, this is to move from the current management, standard medical treatment, leading to a significant rate of death. At 1 month, you can see 5%, at 3 months, 14%, which is very significant, to better outcome. And for that, we need tests to predict the outcome and say, okay, this patient has a good predicted outcome with what we do today, then we should continue. But this patient has a poor predicted outcome, and this patient is eligible for a new combination of drug that we identified in decision, and that will be explained by Professor Paolo Caracini in the next presentation. And the overall, the objective, this is really to improve the outcome of the patient, meaning decrease the percentage of death at 3 months, at 6 months, etc. Thank you very much for your attention.
Merci beaucoup, Professor. It was excellent, very clear, very concise. If you have any questions in regards to presentations, please write it down. We will have time later for the discussion in the discussion part where we have substantial amount of time to discuss everything. So if you have any kind of question, please write it down and send it to us, or you will be able to ask it in the discussion part. But thank you very much. Merci beaucoup. And we will just go on to the explanation of the combat trial for patients from Professor Paolo Caraseni. And we cannot hear you.
Okay. Do you see the screen?
Yes, we see and we hear you. Excellent.
Okay, fine. So, good afternoon, everybody. And it's a pleasure to be here today at this online HELPA event to discuss with you why the combat trial can be important for patients with decompensated cirrhosis. This is the outline of my talk. I start with few words on the clinical history of cirrhosis. As Professor Artù already said, regardless the underlying etiological cause, a proportion of patients with chronic inflammation of the liver ends up to develop cirrhosis. Cirrhosis is classically divided in two phases, compensated and decompensated. Compensated cirrhosis can last for years or even forever and is usually asymptomatic. Unfortunately, every year, 5% of patients with compensated cirrhosis developed decompensation. And at this point, the disease becomes manifest and many dramatic complications can occur, such as gastrointestinal bleeding, ascites, that is the accumulation of fluid in the belly, hepatic encephalopathy in coma, infections, hepatocellular carcinoma, and also multiple organ failure. Thus, it's not surprising that until almost 2 decades ago, the survival of patients with decompensated cirrhosis was very poor, only about 25% at 5 years. In the last years, however, things are significantly changed. First, patients with decompensated cirrhosis are not all equal, but they are very heterogeneous in terms of clinical presentation and risk of mortality, which can be greatly different, as you can see here on the bottom left, depending on the type and number of complications. Second, it's not anymore true that the only perspective of a patient with decompensated cirrhosis is to deteriorate and eventually die unless liver transplantation is performed. We now know that treatments can stabilize the disease and even lead to recompensation in a certain number of patients. Thus, the key messages of this first part are that patients with decompensated cirrhosis are a very heterogeneous population with multiple clinical trajectories and different probabilities of survival. The assumption that the only perspective for patients with decompensated cirrhosis is to die if liver transplantation is not performed is not anymore true. Removal of the etiological cause of cirrhosis, such as alcohol, reaching the alcohol abstinence, viruses, together with the other therapies, can stabilize or improve clinical conditions in many cases and for many years, or even lead to recompensation in a relevant part of cases. However, we have still many clinical unmet needs which require to be addressed. And let's see the one specifically addressed by the combat trial. In the last years, the EASL-CLIF consortium, which promotes the decision project, have contributed to define two clinical entities, which frequently develop in patients with decompensated cirrhosis: acute decompensation and acute on chronic liver failure, ACLF. Acute decompensation occurs when an emergent hospitalization is due to rapid accumulation of large ascites, hepatic encephalopathy, gastrointestinal bleeding, bacterial infection, or any combination of this event. Acute decompensation is complicated at admission in about 20% of patients by acute and chronic liver failure, a syndrome characterized by extrahepatic organ failure and high short-term mortality. This is a very severe condition, and about 30% of patients are transplanted or die within 3 months. But what happened to patients admitted with acute decompensation without ACLF? A recent study has clarified that there are 3 possibilities. First, 60% of patients are discharged, they are not readmitted, and all survive at 3 months with a very low mortality at 1 year, here in green. Second, on the opposite side of the spectrum, in red, 20% of patients develop ACLF and have a survival of only 50% at 3 months. And third, in the middle, in yellow, 20% of patients are hospitalized again for AD, not developing ACLF, and their survival is slightly better, around 70%. And there is no doubt that rehospitalizations are a big problem in patients with decompensated cirrhosis. Many studies indicate that about 20–40% of patients are readmitted within 30 days after discharge. This is really a lot, and about 50% within 6 months. The key message here are acute decompensation is a key event in the natural history of cirrhosis. About 50% of patients discharged from the hospital after AD is at high risk of readmission, ACLF, and mortality in the following months. These patients suffer a low quality of life and represent a heavy burden on healthcare systems. Thus, new treatment approaches aiming to reduce readmission for AD and ACLF are eagerly awaited. And the COMBAT trial is designed to address this specific unmet need. The first aspect of the COMBAT trial that I want to discuss with you is the process which have led to select the 2 drugs forming the combinatorial therapy, human albumin and enoxaparin. As already described by Professor Attu, the clinical trial within the decision process is designed to validate the products selected through the application of system medicine, aiming to integrate clinical genomics data derived from the samples collected in the train-dependent course of patients with decompensated cirrhosis mentioned by Professor Attu. This system approach, however, is still ongoing and have produced so far only partial results. Thus, the selection of the combinatorial therapy was made based by the integration of several elements. First, the analysis of drug prescription in the decision database, which includes more than 2,000 patients, has shown that human albumin is one of the drugs associated with better outcomes. Second, the animal studies performed by the Dr. Trebika's group showed a higher efficacy with the combination of albumin and enoxaparin. And third element is represented by the indications given by the European Commission on the objective and type of the clinical trial to be performed by our consortium. Last but not the least, there is a strong clinical and pathophysiological rationale for choosing these 2 drugs. Talking about albumin, albumin is the most abundant circulating protein in our body. Besides the capacity of expanding plasma volume, albumin is also provided of many other biological properties so that it plays a central role in the physiology of our organism. Together, all these properties can antagonize several mechanisms responsible for the clinical complication of decompensated cirrhosis. Unfortunately, in these patients, circulating albumin is reduced, mainly as the result of the low synthesis by the cirrhotic liver, and is also damaged with a partial loss of its function. Thus, administration of exogenous albumin aiming to replace the physiological function of the molecule is one of the interventions most studied in patients with decompensated cirrhosis. Human albumin is used worldwide, mainly for acute and short-term indication, lasting no longer than 2 weeks, usually in hospitalized patients, both in regular wards or intensive care units, with the goal of treating or preventing an acute complication of cirrhosis. In some cases, however, high amounts of albumin are acutely infused, raising a safety issues in patients at high risk of pulmonary edema. In contrast, long-term treatment lasts at least weeks, usually months, or even years. It is usually performed in outpatients, but it can be started during hospitalization and then continued after discharge. The goal is to modify the course of the disease by preventing the development of complication. Long-term albumin treatment is standard of care only in Italy, while it is used in a minority of patients worldwide. One of the limitations for implementing this approach is related to the need of periodic intravenous infusions. This is what we do in Italy. Human albumin is infused through a peripheral vein in the outpatient's clinical settings, usually every 7-10 days, with the patient sitting in an infusion chair. About 40-60 grams of albumin, 20% solution, and the total volume is about 200-300 cc, can be safely and easily infused in about 45-75 minutes. All the procedure is taken care by a nurse without the need of a doctor. What we found is that the adherence is above 90%, likely because patients feel to receive a clear benefit from this treatment. The second combinatorial drug is the low molecular weight heparin, enoxaparin. Enoxaparin is an anticoagulant administered subcutaneously. This is a typical insulin type-like syringe, widely used to treat or prevent arterial or vein thrombosis in the general population. In patients with cirrhosis, enoxaparin is currently used to treat portal vein thrombosis and to treat or prevent deep vein thrombosis. A seminal randomized clinical trial assessing the effect of enoxaparin at the prophylactic dose was effective in reducing the incidence of portal vein thrombosis, but more important, also in improving the incidence of decompensations and patient survival. We can summarize this part on combinatorial therapy with the following key messages. The combinatorial therapy made of human albumin and enoxaparin has never been tested and is supported by a strong pathophysiological rationale, as the proposed mechanisms of protection differ between the two drugs, hopefully resulting in a net positive effect. The study addresses an important unmet need in the management of a subgroup of patients with decompensated cirrhosis, that is improving the outcome of patients discharged from the hospital at high risk of new episodes of acute decompensation and ACLF, leading to early readmissions to the hospital. Even if both drugs are widely used in patients with decompensated cirrhosis, the clinical indication and the length and schedule of administration are novel as compared to all previous studies assessing these two drugs. I will use the last slides to describe the main feature of the COMBAT trial. The aim of this study is to assess the safety and efficacy of a combinatorial therapy based on the administration of human albumin and enoxaparin in patients with decompensated cirrhosis discharged from the hospital after an episode of acute decompensation. The primary objective is to assess the safety and tolerability of the combinatorial therapy, and then we have a series of secondary objectives to unveil signals of clinical efficacy, to explore the impact of the combinatorial therapy on pathophysiological mechanisms of cirrhosis, to explore the role of selected biomarkers in predicting the response to therapy, and finally to estimate the healthcare costs associated with the combinatorial therapy. The COMBAT trial is a phase 2, open-label, exploratory, randomized clinical trial performed in 9 European clinical centers of the Decision Consortium, 3 in Spain, 2 in Italy and in Germany, 1 in France, and 1 in UK. This is the design of the study. 80 patients, hospitalized patients, will be screened and randomized 1-to-1 within 2 days from the expected discharge following resolution of acute decompensation, and they will be divided to receive the combinatorial therapy on top of standard medical treatment or standard medical treatment alone, and this is the control group. Albumin will be given for 2 consecutive days in the hospital at a dose based on the serum albumin concentration, and then after discharge as outpatients at the fixed dose of 60 grams every 10 days up to a maximum of 90 days. Enoxaparin will be given once a day as a subcutaneous injection at the prophylactic dose of 4,000 units up to a maximum of 90 days. Patients will be then followed for additional 90 days until the end of the study. Finally, patients fulfilling the inclusion and exclusion criteria, but with a less severe disease, as identified by a CLIF CAD prognostic score lower than 50, will be enrolled in an ancillary observational study. This is the timeline of the visits and the assessment of the study. We have 6 visits, a baseline visit before starting the study, a visit at the day of discharge from the hospital, and then 10, 30, 60, 90, and 180 days after inclusion. Patients enrolled in the observational study will be seen at baseline with only 2 visits, which can be also performed by remote at day 90 and 180. So if I have to make a comment, the frequency of visits is quite similar to what occurs in the clinical daily common practice in these so severe patients. In conclusion, making this trial real is a quite big challenge, and it goes far beyond the selection of the combinatorial therapy, since it requires also to guarantee the full adherence to the rules of the good clinical practice. It also requires to write hundreds of pages of study documents, and even more difficult, it needs to respect the budget and the very rigid timeline imposed by the European Union projects. We are still working on all these aspects, but we are fully confident that the COMPAT trial will be on the stage soon, starting recruitment of patients in fall 2023. Recruitment will remain open for 1 year. Thanks for your attention, and I'm ready to take your questions.
Grazie, Professor. It was very clear. So with that, we go to the next stage. And the next stage is, now we know everything about the trial, everything about the process. And how about the recruitment process? Can we have an example of who can be recruited, how the recruitment process go on in a center that is already successful? And this will be presented by Professor Carlo Alexandria. The floor is yours.
Thank you, Marco. Good afternoon, everyone. I'm very happy to be here to share this experience, this presentation with you all. So I will talk about what is my idea of a successful recruitment, and I will show what are the needs of such a center. So I think that the first question is any center suitable for this kind of trial, which, as Professor Caraceni showed, is not a very simple trial, at least in terms of methodology and of implementation. Well, my personal answer is no, because patients have to be in good hands. That means that it is needed a very experienced center in decompensated cirrhosis. For example, my center is part of the EASL-CLIF consortium since more or less 2010, which means almost from the beginning, and it has always been among the most active centers about enrollment in the EASL-CLIF-led studies. Furthermore, such a center must have a strong relationship with the other European and not only European liver centers, because to share opinions, to share experiences is of paramount importance in this field. Then the center has to have widely available and updated resources, which makes these centers a site attraction for the patients, and usually has to have a very active liver transplant program, which also is a very big issue of about site attraction. A successful center, in my opinion, must have obviously a regular ward. For example, my center has got 23 beds, a dedicated liver intensive care unit, or at least an experienced liver intensive care unit. In my center, we have 7 beds of ICU. Must have, of course, a day hospital facility for everything that concerns infusions, paracentesis, transfusions, and so on. Has to have an outpatient clinic for the follow-up. Should have, although maybe it's not mandatory, a dedicated experimental laboratory, which is part, I think, of a third level well-equipped center in a liver transplant program. Must have skilled digestive endoscopy service, of course, because, for example, active bleeding from the GI tract is quite common in these patients, and a very active liver transplant program. In my center, we have more or less 140 liver transplants per year, and this is the mean of the last 10 years. So let's talk about now patients' enrollment, where and when. So you have already listened to Professor Caraseni from about the protocol. And so we are talking about patients that are hospitalized, then discharged, and then treated on a patient facility or in the hospital. So these patients, we meet them when they are first hospitalized. We don't know where. Then they come usually from the emergency room, or they are outpatients clinic that we already know that are followed up, but now are already and again decompensated. Or it can be that patients are referred from other regional centers. We know usually the centers that take part in this trial are hubs. So the referral centers for all the local region. And they should have, these centers should have an actively monitoring ward ICU 7 days a week. For example, I just give you my example. We have an internal chat. We usually use WhatsApp, but you can use whatever you want. When we signal the patients that are coming from the ER, if they can be included in a trial, if they need something that is not in the routinary treatment. So we are quite confident. We use this chat because it's very useful, and it's very useful for patients, doctors, and also for the trials. So patients enrollment, how? The first part, which in my opinion is very, very important, is the protocol presentation to the patients. We go to the bed, we talk to the patient, usually for 10 minutes, 20 minutes, whatever is needed. And after having talked with him about the protocol, we'll leave him written documents in order that he can go through the project then and then again every time he needs it. Then we usually come back the following day or after 48 hours, depending on the patient status, to go to a thorough discussion of the project with the patients, and be careful, take point with the relatives, because in the first phase, we always tell a patient, please think about the project, tell about it to your relatives, and if you or your relatives have any comment or questions, please come back to the following day. We can go to the project all together. So it's a kind of question time when there is a simple questions and answers, question and answer. There are not stupid questions in this case. No stupid questions, and we try to answer every kind of questions. And then once the patient is fully on board, and usually we have we also ask the relatives to be on board, maybe because also patients usually have to be driven to the hospital, okay? So they need support from the relatives. There is the signature part, which is important. Obviously, formally it's very important, but I think the most important parts are those above. During the study, it is very important the patient can rely on us. So what can patients count on during all the study? First of all, a very close follow-up. And I tell you that, and I think this opinion is shared by all my friends and colleagues, patients during the trials usually feel safer than before because the follow-up is closer. They can count on, obviously, hospital resources. They can count on a dedicated telephone line. When it is possible, we use, beside the internal chat, mobile phone that we give that number to the patients, and then they can call us during the daytime, let's say from 8 a.m. to 8 p.m. if they have any doubts, any problems, okay? And the patient have to know that they usually have a dedicated young investigator. Plus, there is always a senior investigator, which is me, always available for doubts, difficult decisions, whatever issue. I answer to the phone, either during weekends or whatever is needed. So I think this is quite important that the patient can rely on all these resources and he feels safe and follow up properly. So let's say a few words about the conclusions. From a physician's perspective, a physician must be clear when he's telling the protocol and explaining the protocol to the patient, sincere, because there is always something that can happen. Adverse events can happen, okay? So we have to be sincere and helpful. Whatever the patient needs, if it is in my power, I try to help the patient. From a patient perspective, the patient must be also clear, all these doubts, all these fears. It must be very, very, very clear about all this stuff before signing for the study and also during all the study. Confident, because if there is no confidence, we cannot do anything. And this is also very important, adherence to therapy and appointment, okay? We are always available to we schedule the appointments and the therapies, but things have to be clear that there is a certain time point, events that must be fulfilled. Well, from everyone's perspective, it has to be very clear that we are joining efforts, physicians and patients, to achieve a better health for them. And that's all, folks.
Grazie, Professor. Very clear, and it should be noted then when you are making decisions to participate in any kind of a trial, it's important to involve also the relatives, as you said, and family members and caregivers, especially when we are talking about patients with decompensated cirrhosis and patients that are like having a really, really tough time with their disease. So they all need to be informed because they all need to make right decisions to improve the health of the patient. Thank you very much. So without further ado, we go to the next presentation. So when you decide then, and you decide as a patient that you want to be part of a clinical trial, and you discuss it with your relatives, family members, and you sign the papers that you are part of the clinical trials. So what does it mean from the ethical perspective to participate in such a trial? So this will be presented by Professor Itzer Della Cona. Welcome, the floor is yours.
Thank you. Thank you, Marco. Hello. Thank you very much for the invitation. I will try to share my screen. Is that okay? Is it now?
Yes, we see the presentation.
Working, right? So in my case, I will speak about the ethical and also legal and societal issues related to the project and the trial, because we have a specific work package in this consortium and in this project dedicated to this. And I think it's important to share with you this design, because if you compare other projects with our proposal, you will see that there is a difference. We are concerned from the very beginning to provide this transversal, I would say, view to the project. By now,
Professor,
what
we see
sorry?
the slide number 15.
Ah,
Is that
sorry. So
okay?
it's not working. Sorry, it's not working. I think that I need to start again sharing the presentation. Sorry. So I'm sorry. I need to share screen first, right? The share screen, and then.
Then you choose the presentation, and in the presentation you can go to the slide number 1.
Oh, okay, sorry.
Ah,
Is that correct?
excellent. Yes, we can see
Sorry.
it. It's perfect. Thank you.
Sorry. Then what I want to share with you is what we have been publishing for patients, for anyone interested, because we want to deliver our results with the society as soon as possible. We have several documents that maybe are interesting for you. The first one is the public engagement strategy, because this is about also how to design a clinical trial to align societal interest. Also, we have a kind of publication related to codes of conduct that I think it's a good way to start analyzing by the consortium what we have regarding ethics. And the one that I want to highlight today and to share with you, and for me, the best scenario will be receiving some feedback from you, is deliverable 6.7 that is in open access, related to how we can make assure that the informed consent process and the informed consent itself is okay. It's a checklist for participants to assure this, and other mechanisms for those unable to give a written consent. And you will see that there are plenty of ethics in our project, but I need to focus on 3 issues. The first one is taking into account this approach. As I said, ethics is present in our project, but it's under the umbrella of this new conception provided by the European Union as a transversal agenda that is called responsible research and innovation. The first one is ethics, of course, but we also integrated the issue of gender equality, the gender perspective and gender equality.
Dear Professor, the slides are not moving.
I don't know what's happening, but it's not a problem for me. So I can.
Maybe if you can go one by one, when you want to discuss about it, just click on it.
Okay, I'm clicking.
Thanks.
So right now I'm talking about responsible research and innovation. That it's a very simple concept. It's about ethics. It's about ensuring gender equality.
Yeah.
And yes.
You are on the screen.
Yes.
Above. Yeah. Maybe if you want to share
yes.
Not the PowerPoint, but share the screen.
Yeah, I try to go to share screen first, right? And now?
Yeah, this is perfect now. Now we see responsible research and innovation.
Yeah. But the next one is not moving. Okay, let's try. It doesn't matter. I can live without PowerPoint, you know. So, and it's very simple. So I was talking about ethics, gender equality, open access, and scientific education, and public engagement. So what is public engagement for us? And this concept has been integrated also in the design of the combat trial. Is align societal interest with our research proposal. Our research proposal is composed by not only the clinical trial. I want to highlight this comprehensive view. It integrates also other research processes, and we are dealing with, of course, assuring the protection of humans participating in the trial, as Paolo commented, but also how we handle the information provided and included in part of, for instance, human biological samples that we need to move forward in this research, in these biomedical research processes, and also how we handle with data. So here you see that ethics is composed by the classic issues regarding the combat trial. So how to assure that patients are being informed to make a free and autonomous decision, but also how we take care about and take care of the data and the information involved, because this information is of course, confidential, but it's very sensitive. There are specific and special categories of data that should be protected in order to avoid, for instance, discrimination, etc. That's our perspective. So that is why in these minutes, and maybe this afternoon or later we can discuss, but I invite you later, today, tomorrow, to check this checklist that we have produced. And we are very, very interested in your opinion, because part by part, it's analyzing all the information that should be provided to potential participants in order to decide whether or not to participate. And this is my contribution today, this comprehensive overview, not only focus on clinical ethics, but also on this more wide concept of responsible research and innovation. And I think that maybe we can save some minutes to discuss with the patients or the lay members here involved in order to move forward. That's all. Thank you very much.
Gracias, Professor. And with that, we are just diving in to the discussions. So we will open up a floor for the discussion. The main question is, for example, how can a patient association work together with the recruitment center? Can we help the patients that will be enrolled? Can we help them with additional information about the trial, about it basically is the same information coming from different sources, because we noticed when we work in the patient communities and when we discuss with other patients, it's sometimes very helpful when you get the same information from different sources, from doctor, from nurse, from another patient, or from patient association. So I'm opening up the floor. Do we have anyone who wants to ask the first question? So I think I see the Teresa. Yes, the floor is yours, Teresa.
Yes, thank you. I enjoy a lot the presentation. Very well prepared information for patients. And I have three questions. The first, at the beginning, with Professor Pierre-Emmanuel Ratou, in relation with when he presented the acute decompensation in cirrhosis, I thought it was directed to have a prognostic test, because he talked about some patients will have a rapid discharge, but others will have to consider more aggressive strategies. So my question is in relation with this prognostic test, if you have some kind of biomarker or a scoring, having this in the practical day-to-day for patients.
Yeah, thank you very much. This is a very important question you are mentioning there. And it's true that currently what happens is that the patient is admitted to the hospital for an acute decompensation, meaning that yesterday this patient did not have symptoms and today he or she has symptoms. And immediately we do not have a way to stratify patient. That means that we are not able to say this patient will have a good outcome with what we are doing immediately, and this other will have a poor outcome with many complications, with requirement of liver transplantation in the very next weeks or months. And this is one of the goals of decision, not only to develop a combinatory therapy as presented by Professor Caracini, but also to improve the prediction of the outcome. And for that, we did a huge effort together with the work of Joan Claria in Barcelona, with many teams in Europe, trying to dig into what contains the blood of the patient. It means what contains in terms of very small things, the microRNA, the expression of the genes in the blood, the vesicles circulating in the blood, the metabolites, many small things that we analyze very accurately in more than 1,200 patients with acute decompensation cirrhosis, and we add immediately this very precise information on top of the data we have day after day, meaning is that man, a woman, what age, what history, what blood test. And with that, we are trying to build at the moment. We don't have that for now, but we are really in the process of developing that, develop a test able to say this patient has a good outcome, this patient has a poor outcome. And we want, of course, to focus our efforts on the one having a poor predicted outcome.
Thank you. Thank you. Another thing is in relation with the clinical trial, the combination. I understood that some patients could enter in the clinical trial and receive both treatments, albumin and enoxaparin. And in some cases, after finishing this treatment, perhaps they could receive or enter in another study, ancillary study, if they have some type of cliff score with treatment with SMT. But I did not understood correctly if this is a follow-up or this is another study.
Yes, I've been probably a little bit too fast in explaining that, but it's an important point. I mean, to be included in the study, you need to be in the group of at high risk of acute decompensation, ACLF, and new hospitalization after discharge. And what we use to define the high risk is a cutoff of the Cliff CAD prognostic score. So if you are above 50, you can be considered a high risk patients. And so if you agree and to participate in the study, you can be randomized to standard medical treatment or to standard medical treatment plus the combinatorial therapy. But if you fulfill all the inclusion-exclusion criteria, but you are a less severe patient because your Cliff CAD score is lower than 50, you can participate in an observational ancillary study. So we just need to have a baseline visit with biological samples, and we will follow you for a maximum of 6 months, and even the visits can be a remote visit by phone or by web, just to catch the major events. In these cases, the patients will just follow the standard medical treatment as they receive for their disease.
Standard medical treatment. This means
so,
follow.
And the reason to perform an ancillary study and observational studies is to increase the number of patients providing biological samples in order to increase the sample size, and they will be useful for giving more accuracy in the analysis of the biomarkers that we want to test in the study.
Yes, thank you. And Marco, may I have another comment? Because
yes, Teresa, you said 3 questions.
Sorry, I was funny because this acronym SMT, this is a standard medical treatment, or I understood another thing. So this is a very good clarification. Thank you. And my comment is
what sorry about that, but it's what we use. I mean, that's
yes, but
it's the best treatment. Is
in
the
this
best
field,
treatment for
and
patients.
so it could be a misleading. Sorry.
Yeah, you're perfectly.
And for me, one of the critical issues in this study is the information and the pluridisciplinary team, and that you are always in contact with patients and families. This is the condition, the most important, to have very good adherence, not only treatment, but appointments and controls, and the safety, because you receive calls and you answer questions, and not only resources, and yes, also resources in the hospital and having a liver transplant. But I think this is the way to incorporate best quality of life and survival results for patients. And my last question, sorry, because it's a little long, is for Dr. Isiar de Lecuona, because I saw these concise concepts very clear, but I have a question. What is the interpretation or the perspective of public engagement? What do you mean on public engagement?
Shall I answer now? Thank you, Teresa.
Yes,
I know
please.
that if I introduce this concept would be a challenging issue. Yes, you're right. This is the most difficult, and that is why we introduce it from the very beginning, and we are compromised with that. It's very difficult to assure responsible research and innovation. It's very good to have this slogan, but very difficult to move forward. The thing is that in every step of decision, what we have been doing is working from the interdisciplinary perspective to assure that all the views have been integrated, including discussions among us, for instance, how we design a trial or this intervention. This means that we need to justify, for instance, and the agencies are going to ask us why the gender perspective is not represented, things like that. But the challenging issue regarding your question is how to design for instance, the combat trial, aligning your interest. And I think that this is an example. Today is an example. But if you want to have more information, you will see that there is a specific deliverable on different possibilities about how to integrate this public engagement perspective. But for me, in my personal view, we need to, of course, integrate your perspectives as patients, as lay, as citizens. We are all citizens from the inception of the combat trial. And I think that partly we succeed, no? And if you see the consortium, you will realize that you have philosophers there, philosophers of law, you have professionals like Paolo, Pierre Emmanuel, in order to assure also this conception. It's challenging. We don't have the perfect solution, but we are trying. Thank you very much. And please, if you have time, I ask you to check our deliverables, all in open access and all for lay people and patients. For us, and for me particularly from BP6, and I'm sure that Paolo, Emmanuel, and everybody will agree, we need your feedback, and it's part of the process. It's not only explaining you today, it's the first step, but please send us your feedback. Thank you very much.
Yes, thank you. Welcome.
Thank you very much. And it looks like we are getting questions in three. So three questions from Teresa, and now we have 3 questions in the chat. So maybe Milan, if you can just start with the first question, and if you are there. So Milan posed a question. So, for example, what are expectations from the recruitment center? Where do you see a place for a patient expert or a patient representative to support you? So I don't know to which one to ask this question, but maybe you can say it from your perspective. Do you collaborate with any patient group in your center? Can center and patient groups collaborate on that? Paolo, you are muted.
Yeah, I can start first about starting from the last question from the patient collaboration. We have a local association of patients with liver disease. We collaborate with them mainly for the assistance of patients coming from outside the city or outside the region, and also for any type of informative need about the hospital and about the where to stay while maybe their relatives have been studied for liver transplantation. So we have a local patient association, and then here in Italy we have a national association for liver disease, and Marco knows very well the president of our association, that is called EPAC. What we usually do, we just talk with them and diffuse and share the study through their social activities. So this can help both for recruitment and also for exchanging information with the patients. And that's the one point. Of course, there is a place for patient interaction. I think is very, very important because we have to work together, and even when we are both involved in the study. So they will be very important to have a common goal and to work together for achieve that goal. So that is in the case of the trial, to do the trial as the best of our possibilities, and also this will be also, I think it will be very important to make a much stronger connection between patients and doctors also for after the study. So
may I add something from the ethical perspective?
Yes, please. Yes, thank you very much, Paolo. Yes.
Oh, what Dr. Carrasini said is crucial, but you need to take into account that by now the regulation on ethics committee, research ethics committees that should review the protocols here, there, and everywhere include the perspective of the lay member and the patient perspective. This is a step that is also crucial because it's not only a question of having a conversation with your doctors or you rely on your doctor, etc. But there are also this kind of controls, that guarantee the participation. This is tricky also because maybe patients are in a way biased. We all are biased, and we need to find an equilibrium. But I think that it's good to have this in a compulsory way, trying to avoid conflict of interest, etc. But there are different steps in the process. And this independent overview includes, and the regulation at European level includes it, the participation of the patients and also the representatives. I've been part of, and I'm part of several committees, and we discuss many times, how representatives are there, etc. So I think it's included and could be improved, of course. Thank you.
Thank you very much. Prior going to Milan, just to check, Pierre Emmanuel, Professor, you wanted to say something because you opened up your mic?
No, I completely agree with the fact that involving patient association is very important at many steps when building the trial design, but also once the trial is ongoing, because it's very reassuring for the patients willing to participate, discuss with other patients. So we have this experience, and clearly there is a crucial role of patient association in trial development and trial performance.
Thank you very much. And we go to Milan. You raise your hand. Sorry, yes, Professor Lacuna, you wanted to comment? No, let's go first to Milan and then back to the Brian.
Yes. Sorry, thank you for the magnificent event today, for the information which you delivered today for us, like a patient association, and the needs, what we need to in the next period, and what to expect. Let's say, I hope. Connected with the three questions which I asked you, my point was that in a moment has some kind of defined guidelines how the patient representatives can be part of different kind of clinical studies. Has a special academy in Europe, which half of the members of European Liver Patient Association finished this academy, and they're trying to involve more patient perspective in their clinical trials. in the context of what I was asking, that I must want to comment that I was trying to give a better view of the things for the future. Also, European Commission and some of other bodies for the next round of the clinical research, giving a wider perspective for the patient recruitment, and of course including in the process of the clinical trial. Thank you for the answer.
Thank you very much, Milan. And we go to Professor De La Cuna. Yeah.
No, I saw that, well, something that we have as a pending issue is to translate in different languages, the information, the checklist. For instance, we produce a checklist to assure informed consent. And well, in recent days, we were discussing with Paolo and Amelie and members of the consortium the need to translate it into different languages, of course, to adapt it to each site. But we are still ongoing, and this is something that we will do for sure. And that's all from my side.
Thank you very much. Professor Caraseni, you open up your mic. You wanted to add an opinion?
No, I think
okay.
We already.
So with that, we just captured that last part that was said and connected to the next question that was here. So do you see any difference in the patient recruitment per country? Because you are saying that in 4 or 5 countries you will recruit the patients. Did the recruitment already started? Where it started? Do you see any difficulties? Anything that we as a patient community can help you with?
Well, I can start. Well, the recruitment will start in September, October 2023. We will have 3 centers in Spain, 2 in Barcelona, 1 in Madrid, 2 in Italy, 1 in Bologna and the other 1 in Turin, 1 in France, in Paris, 1 in UK, in USL, London, and 2 in Germany. 1 is Münster and the other 1 is Aachen, if I'm right. Well, the recruitment has to be performed in patients still in the hospital who are almost ready to be discharged after resolution of a complication of the disease. So the recruitment will be mostly will be in the hospital, so the physician will be in contact with the patients during the hospitalization. And also Carlo Alessandra showed very clearly how important it is to have a relationship with the patient over the hospitalization, with having more possibility to talk with him over time, and not to ask for the permission and get the signature of the permission at the same time. So that's something that I think that will be important. It will be our duties to be very effective and empathic.
Show your earphones if you don't mind.
Yeah.
They're not great, no ones.
After discharge, the main thing will be to have the patient come to the outpatient clinic to receive albumin every 10 days. This is why I showed the slide in my talk, because this is absolutely common, is a standard of care in Italy, but is not so common outside Italy. So maybe this is maybe a key issue for the adherence. I'm quite confident, because if patients in Italy are happy to come, and I can tell you that they are very happy and they want to come, I believe that they will be the same also outside Italy. But this can be a tricky point, the adherence to the schedule of albumin infusion. We are talking 1 infusion of about 1 hour every 10 days. So it's not really a lot.
Thank you very much. We should add here, from the patient perspective, or patient organization perspective, we are not just demanding things from you, but we are just trying to see where we can come together and how can we help you. Overall, a patient association cannot recruit patients, but definitely we can help with their questions. We can help with the questions about the study protocol, which you described to us. We can also link a specific question from a patient to a professional who has dealt with that questions, as many, for example, with the principal investigator. So we can really help in that way. And the questions could be from the patient or the relatives or the family members. And as presented by Professor Alexandria, is very important also to include all that are there for the patients. As Professor Saraceni said, they all need to make sure that you are adherent and you come to the treatment and you stick to the treatment. So yeah. Thank you very much. Do we have any other questions? Okay, then with that, I will just say, if you have any questions later, and if you are looking at this video later, and there is a question that you really want to see answered, please send this question to ALPA office or contact us, and we will find the right person to answer your question. But with that, I will just say for today, thank you very much for all the professors that did the presentation today. For your contribution from our side is very highly appreciated that the presentations were done in the lay language style, so that really a general public can understand what is this all about. And from all the patients at European Liver Patient Associations, thank you very much for your collaboration, and hopefully see you soon.
Thank you.
It was my pleasure.
Thank you. My pleasure. Bye-bye.
Bye-bye. Bye-bye.
Thank you. Bye-bye.